Alice Shund. I'm a Chief Nursing Officer. Currently, I'm the Sub-County Public Health Nurse for Dagoretti Sub-County. Thank you for giving me that opportunity, at least to share my experience, challenges. Sometimes back when we had the COVID pandemic, I was deployed to Kibera South Health Center, which had been identified as an isolation center for patients who were suffering from COVID. On the first day, it wasn't easy. We met there on the first day. As a team, I had newly employed nurses, about 15 of them, very young ones, and 2 doctors. I had also another team lead by the name Mangati, and it was really a confusion because none of us had nursed a COVID patient. There was a lot that was going around that this is a killer disease, you perish within a few hours. However, we had undergone like a 3-day training just to orientate us on what is COVID, how to manage, how to use PPEs. But all in all, we are human beings. We had our own emotions and feelings. And it wasn't easy, as somebody may think, because I'm a mother. And looking at the young staff that had been employed to take care of the COVID patient, I was seeing like these are my children. And I had a lot of support on my side and on the side of my staff. One of the things that was ringing in my mind is that, okay, I need to put this place in order, because anytime we were expecting patients to start trickling in, we were given a facility. So I needed to identify rooms, set beds, do the signage, which room is for which service. I needed to get away how these patients are going to feed. I needed also to get away how they will be transferred, which facility will I transfer these patients, especially the critical ones who need ICU, because I knew that was just an isolation center. And most likely we were to get patients who are critically ill that we need to transfer out. So many things were lingering in my mind as a team lead. Am I going really to achieve? How am I going to handle these patients? So I had an introduction meeting with my staff. We set the rooms, we made the beds, we did the signage, we identified which wing for male, which wing for female. Of course, not forgetting that even our own healthcare workers were going to be affected, and we needed also to set a room for our own healthcare workers. So it took me 4 days and everything was set. And on that 4th day, we received 3 clients or 3 patients. That is when I noticed we did not have enough oxygen cylinders. We had only about 2, although we had placed our request for procurement or for supplies of more oxygen cylinders. So lucky enough, the oxygen saturation levels for the 3 patients were not bad. Only 1 required oxygen, and our team managed to fix. So at least it was a matter of urgency. I did a call to our county director, who made sure we got some cylinders from Mama Lucy, from Bagadi. So at least in that day, we received 10 more oxygen cylinders, and I knew we were well to go. So I was at a crossroad, which drugs are supposed to be used, but I had a team of 2 MOH. So they told me they're going to treat according to the signs and symptoms. There's no worry, so long as we have oxygen and all that. all went on well, but it was not a soft landing as such. Personally, I had my own reservation that was ringing in my mind. I have a family, I have a husband, I have grown-up children. And the question that was running in my mind is, okay, suppose I get infected, what is going to happen? Is this call worthy to be exposed to such a dangerous disease? Am I the one going to infect my family? And it kept on going on in my head. But since it's a calling, I'm a nurse, and nursing has been my calling since I was a young child, I said, okay, I will go for it. I have grown-up children working. They told me, Ma'am, if it's your wish to serve the patients, we shall pray for you. But the challenge was my husband, who was like, must you do it? Why can't you resign? And I told him, resigning will not be a solution, because whether I'm in the house, at a given point, I will go to do shopping, I'll be on the supermarket and all that. I stand to be infected even if I'm not a nurse. So we discussed, and I told my husband I was ready to move into a hotel, because we were being given a provision of moving from your family and staying in a hotel so that you can come from the hotel to work in your facility. So I told my husband, there's that provision, I can move, pack and move to the hotel. I'll work from the hotel until I finish my assignment. He was so quiet, so reserved. But after some days, he told me, it's okay. This house has got so many bedrooms. You don't need to work from a hotel. Then, of course, I appreciated for him considering that. So I had to move some of my stuff from my major matrimonial bedroom to another bedroom in our house. At least what I needed, what I knew I require most. And I made sure there was a provision bathroom outside, so that when I come from duty, from my vehicle, I just go to the bathroom. I do my laundry there, I bathe, then I go straight to my bedroom. So it wasn't easy, knowing that I've been in this marriage for over 30 years. I've never had such like separating bedrooms and all that. But because of my nursing calling, I had to do it. So it went on like that, with a lot of support from my husband. As much as we could communicate on the phone, I come in, I say hi, I take my food, I eat, I go to my bedroom, just to evaluate what is going on. Are we doing the right thing for our clients? What do I need to know more? So I kept on calling different people to add more knowledge, so that at least we could take good care of our patients. At our place of work, we had our support from the county, from the sub-county MOH, from the county directors. All the doctors were there for us every day, calling, coming even on the ground, although they could not go inside the wards, but they could come to my office, we discuss. Patients came in so many. There's a time we had even a capacity of around 60 patients, some of them pregnant women, old age, and even some of our staff from Bagati, from Mama Lucy, and other health centers. So actually this was a burden on me. I was looking at it. If I failed the patient, I failed my county, I failed my government. So long as I accepted that I'm in for it, I should do my best. If I was to die, let me leave a mark that I did my best. So my low moments came when one of the patients, as I was doing the changing of, I was assisting one of the nurses to do bed making. As we were to change that patient, just did a sign language just to call me. We had not reached his bed. And I went near and told him, give me a paper and a pen, I write my will. Give me a paper and a pen, I write my will. In a very low tone. And I think it didn't sink in me. Why he was demanding for a paper and pen to do the last will. Then I think I reverted back and said, what is it? He told me, sina nguvu. Sister, sina nguvu. I told him, you are going to be okay. I dashed out because we were only nurses who were doing the bed making. I dashed out to go and look at the MOH was in the room. So I went, I told our MOH, he's sick, and he's saying he's just weak. Just come in, doctor. Doctor told me what are the saturation levels of oxygen. I dashed back again to the ward and was saturating now at around 68. So I went back again. I told the doctor, please come. The saturations are going down. Kept on looking at me. I went at the bed. I told him, you are not going to die. We are going to do our best. And he kept on looking at me. Weakening, the eyes were just going. You see, I'm just looking at, just like weakening. I went back again to the staff room. Then we came back, the doctor was there. It was weak, he could not talk. I've not given him a paper to do the will. I've called the doctor. I think we are not doing much. So I was just doing the reassuring part of it. Then eventually, doctor, they did their best, did the resuscitation. Within like a span of 22 minutes, was dead. This is a death that I will never forget. It's a health man who came in very healthy. Yes, he had COVID, but he was very strong. As they were resuscitating, I was looking for an ICU bed at Kenyatta. Eventually, we were told we can refer them to Kenyatta or to KU. So I was looking for ICU bed at Kenyatta. I was busy on my call, trying to reach Kenyatta to get a bed for me. But unfortunately, we lost him at Kibera South Isolation Center. Sometimes I think our limitation was just oxygen and oral drugs, oral injectables. Later, after that, we had also like a meeting again. Then we all brainstormed. Lucky enough, everybody felt like there is something that maybe should be added in the management. And those were lab investigations. So that was that. We continued managing all the patients. Anytime I got a pregnant woman who had COVID-19, I was very cautious. This is a mother I do not want to manage in the isolation center because I knew I'm managing two lives. This is a mother I could refer to Kenyatta, I could refer to KU University for better management. I did not want that change of scenario where I'm going to lose a mother and a baby. So any pregnant woman who was COVID positive, On admission, the next assignment was to look for a bed to transfer to Kenyatta or KU University for better management. And on that area, I think I did well with my team. We did not lose any mother, neither any baby. At least all our mothers delivered safely, and they had live babies. So we nursed all our patients. I think in a duration of about 8 months, we had only lost about 6 patients. That is a big number. 6 is a big number because it's a life we have lost. We lost about 6 patients, different intervals. And of course, there is that bit of counseling the relatives. Some relatives could not come in to pick the bodies. Kibera South had only one room for holding the body before it's transferred to the mortuary that has been preferred by the relatives. So there are scenarios where relatives even were scared of coming just to fill the death certificate and tell us where to transfer the body. So in that scenario, if we call the relative, because we used to take the number of next of kin, if the relative does not come, then we were taking the bodies to the city mortuary. Then wait for the relatives to come and claim the body. So most of them stayed alone. The bodies stayed alone in the city mortuary. We don't blame the relatives. They were also scared of the infection. But some came, they were packed for the bodies together with the public health officers. They escorted them to dispose the bodies at their respective rural areas. Of course, the relatives were not touching the body. They were the public health officers who were doing the burying of the bodies. The burials, relatives hesitated to pick the bodies. Many bodies stayed at city mortuary for so long. But when they came inquiring what to do, we could give the notification, the death notification. They go to city mortuary. Then when they come that they want to pick the body, it was my mandate now to conduct the public health department so that we can get the public health officers to organize on how to assist the relatives to transport the body and bury. Of course, we know there were no funeral ceremonies. It was just arriving with the body and burying the body. Maybe the service could be done later. There was a limitation of the number of relatives who were to attend the funeral, a limitation of up to 20, 25 close family members. Even other area neighbors were not even allowed to attend. But all in all, I think I give all the glory to God. I was, I think, the old one out in that setup, because initially in the protocol, it had been said that anybody above 50 years should not work in isolation center. I was around 53. So I was wondering, I asked my boss, now I'm 53 already. I've been posted to team lead in the isolation center. What happened? And my boss told me, Alice, you have to go. God is with you. And I knew, yes, God is with me. And I worked for like 8 months in the isolation center with so many patients. I never contracted COVID. I came out clear. However, I lost a staff by the name Mr. Gitau, a widower who had just lost the wife to cancer about a year. Gitau was the only surviving parent. Unfortunately, we lost Gitau due to COVID. He came in driving, dyspneic, he could not breathe. We connected oxygen. We looked for an ICU bed in Kenyatta. We got. Gitau was transferred to Kenyatta, reached Kenyatta, and just said the last words to the colleague. One of the colleagues was the one transferring him. One of our nurses was the one transferring Gitau to Kenyatta. And Gitau told the nurse before he was wheeled to ICU, kindly, if I die, don't take my body back home. The graves will be too many for our children because I've already buried my wife there. Don't take me back home, bury me to Lang'ata. And actually, Gitau succumbed and we buried him in Lang'ata. So that is how bad the COVID was. It took us a lot of trauma, psychological trauma, a lot of fear. But all in all, we fought it as strong heroes. And we were able, out of the many patients we received, I think we lost a few, but we managed a big percentage that was discharged. My recommendation would be, COVID is still with us. We need more trainings, a lot of capacity building, so that we know the really details of managing. We have done it. We don't hesitate to do more classes because COVID virus are mutating every now and then. I know another one will come. Are we ready to handle it? We need a lot of capacity building, a lot of exposure, a lot of benchmarking, so that we can learn a lot of details on managing our patients and maybe getting a healing accuracy of maybe even 99%. And we appreciate our leadership at the top of the country, at the county, at the national. They did their best, actually. Because looking at the percentage of what we lost and other countries, we were even much better as compared to other countries. However, we need more of updates, more of the trainings, more of benchmarking in other countries. I'm a human being, let me not lie. COVID never left me strong. And I can say that if today I was told to go and work in an isolation center, no. I will support from another angle, but not inside an isolation center and not inside a COVID ward. Yeah, I think to some extent it left me more weaker. Just thinking, what is that we need to put in place to do the best for our patients? Thank God I did not lose anybody from my family. I did not infect anybody in my family. And I think as I went to that isolation center as a front warrior, God was with us. As much as we lost one of us, at least we had God's protection. And we really feel for the family of Gitau. We know the children are all alone now, but we have always done a follow-up to know how they are doing with the relatives, and they are doing well.
Thank you very much for having me. My name is Dr. Kibe Victor Wathugi. I'm an infectious disease specialist, medical doctor by profession, and I work for Nairobi City County Government, the health department in the medical services sector. where I head the division of non-communicable diseases. Currently, the division has 3 units, that is the cancer unit, the mental health unit, and the non-communicable diseases unit, including diabetes, hypertension, epilepsy, among others. I quite recall very well when the first case of COVID-19 patient was reported in our country. We were having celebrations for the World TB Day. And we were in one of our local primary schools where we were trying to do advocacy because TB, is a highly infectious disease. And yes, then there was the then Cabinet Secretary for Health made an announcement that there's been a reported cases and all public gatherings had been suspended henceforth. Thereafter, 2 or 3 days after, we were contacted by the Ministry of Health, a team of experts. We were trained by the Center for Disease Control, the CDC, and luckily I was among the very first healthcare providers to be trained on basic infection prevention measures to try and contain the disease. I recall at that time we did not really know much about COVID-19. We were relying mostly on information from the World Health Organization and also experiences from other countries which had been hit hard by the pandemic by then. So yes, that's how it all started. And I remember at that time when we had very few cases in the country, there was a lot of deliberate efforts, both by state and non-state actors, that is the government and other organizations, to try and see how to combat and at least try to avoid what was happening in other parts of the world. And that made me a frontline responder to the disease. Of course, it was a multidisciplinary team. We had the lab team, we had the public health team, we had people like me, infectious disease specialists, we had epidemiologists. So it was actually a well-constituted team, including the security agents, because they were also players when the pandemic broke. So yeah, and that's how it all started. Initially, my first county where I went to respond was in Garissa County. And then after Garissa, I moved further up to Wajir County. I did several trainings there for the healthcare providers. As information was coming, we were also setting up a curriculum to see that we equipped our healthcare providers and even the general public with the right information. So after that, I moved a little bit to Meru, Homa Bay, and then now with time, the numbers started increasing, and especially here in Nairobi. And I remember at one point, even before the lockdown, we had to evacuate people from their households if they had signs and symptoms of COVID. We were able to test them, send the samples to the national reference laboratories or to Cambridge for that, so that we could get the results as quickly as possible, so that then we know how to respond to the pandemic. Yeah, so that's how it all started, and that's how I got myself into the healthcare frontline responders. It was quite challenging, I must say, because my son was around 6 months old at that time, and I felt I had been exposed because I was dealing with patients, people who had turned positive for COVID. So one of the decisions that I made at that time was to move my family. So I moved my family to go and stay with my sister-in-law. We would do all the infection prevention control measures, the gloving when you're handling patients, the masking, the use of sanitizer, alcohol-based hand rubs. But then I still felt that there are people even in the community, not just my family, who I had to protect. And then this meant that there was very limited interactions. If you're not dealing with fellow healthcare providers or the patients, basically, majority of us tried to avoid, mingling with the community because we didn't know to what extent were we contaminated. I remember that time we did not have vaccines, had not yet come. So basically, I would just wake up in the morning, get ready to work. Of course, now we had a team that had been constituted both at the national government and the county level, because not all healthcare workers were responders. We had identified teams of people who had some background training on, infectious diseases or to deal with these cases, because we also didn't want to expose our entire health workforce to the disease. So basically, that's how it all started. And then now the most difficult time came when we had the lockdowns, because we had passes, we could go anywhere. But who are you going to? Because everybody else is indoors. I think the only people who we really encountered were the police officers. The law enforcement are out in the night, but then again, there's nobody, except of course a little bit of movements. Much later is when we started feeling the effect, because at that time we were really committed, we had the energy, we felt we had to do this for our people. It is what we were trained to do, respond in such instances. But I think we started feeling the effects of, that now after the pandemic, because, it was quite a traumatizing time, especially for the responders, because at one time, of course, you were seeing people dying, some very sick, others could not even afford, and of course, not everything was free for everyone. And of course, everybody rushed to the free services at the very onset, which means the bed occupancy was all-time 100%. So you have these patients, they need oxygen support. They cannot afford the private facilities, and our government facilities are overwhelmed. So it was quite a traumatizing time for us. Sometimes we would even go to evacuate patients, and they wouldn't even make it to the hospital. We are called, we have this patient, we get the case definition, we do our assessment, and then we lose them before even they got to the hospital. Luckily, I know and I can confidently say that majority, very big percentage of those people who got sick during the pandemic actually recovered and they are well. Yes, however, we noticed, of course, those people with underlying comorbidities, other conditions were really affected because scientifically speaking, their immunity is already compromised. So they were at a higher risk. They were more vulnerable to catching the disease. You cannot live. So if you have a store, you've exhausted your stock. So the trauma I'm talking about here is more of psychosocial. The mental, that feeling of, I'm not okay. Everything is not okay. It's end month. I don't have money to pay rent. And because I didn't work, so I didn't earn a salary. But, this kind of trauma, these are kids, they're used to going to school. All of a sudden, they're at home. And where are they at home? They are just told there is a disease outbreak. And all of a sudden, everybody in the family is wearing masks. For a kid, for a grown-up, it's easier to understand. But you can imagine for a child, they are wondering why all of a sudden is everybody putting masks, everybody is keeping distance, and we are used to, Africa, the way our social cultural setup is that, we bond, we want to hug, we want to hold them close to you. But then this was now not happening. I remember some of our colleagues got sick, and very unfortunate, we even lost some healthcare providers who were in the front line. I remember a case we had at one of our isolation facilities at the Kenya Medical Training College, the Nairobi campus, where several of our staffs actually got sick to the extent of being admitted in the hospital. And now you can imagine, again, like we are talking now, you can imagine the toll it had on the rest of the team. Yeah, but basically, yes, it was quite a tough time. We braved it, so we now started organizing, skits. We would do team building activities just to see that, we are having some safe space, especially for our mental well-being. So we would go hire the public address systems and play some music, dance, jam, do all these things. And also we also started encouraging the community to do the same because the stress was all over. Yeah, so those were some of the things that we tried to embrace, and to date they still work. Because we realized actually we have been having this burnout all along, only that now during this time of the pandemic, it was accelerated. Yeah, I think the disease taught us quite a lot. It also unlocked potentials that people didn't know that they had. For some companies, they realized they had some positions that they really did not need. And then they realized some tasks can actually be done from home. Don't have to, physically be present at your workstation. And it was being effectively done. We even learned during the pandemic, even for our academia, we learned that, we don't have to go to a classroom. You can stay at home and continue learning. So there were those, of course, the pros and the cons of it. But I tend to look at it from the positive side, that we learned that you can do a micro garden in your backyard, and you don't have to buy everything from the markets. And we also learned that probably we were spending a lot of time at work and having very little time with our family members. So those are some of the positive good things that we learned from the pandemic, especially that aspect of having to work from home. And we have embraced it, because even as late of yesterday, I had a virtual meeting. So it also showed that we could, not spend so much resource on physical meetings, because basically, if you want to do a virtual meeting, the much you need is just data, probably on a smartphone or a laptop. And you can meet with someone who is in Mombasa instead of traveling to Mombasa or them coming to wherever you are. One thing that I realized is that when it comes to matters health, it has to start with individual responsibility. Much as this was an infectious disease, the way you responded, your discipline, your self-discipline, determined the risk you're putting yourself. And when you look at it, it's not just for the COVID. Most of these infectious diseases are actually avoidable, unlike non-communicable diseases. And there are usually enough preventive measures that have been put in place. So if I don't protect myself, I'm not protecting you. If you're not protecting yourself, you're not protecting me. So I think the one thing that I really learned is that when it comes especially to infectious diseases, we have individual responsibility to contain the spread of the disease. Remember one thing: the virus does not move. The bacteria does not move. It is us who move the pathogen. Even if I left COVID here on this table by maybe spitting, the virus will stay there. It can't go anywhere else. Even if maybe it could travel maybe a meter or so through a droplet, but it cannot go beyond a meter. Okay? So it stays there, literally. It can't go. But if as I move, I am moving the virus. So basically, in one word, I would say it's all about responsibility matters health, and especially infectious diseases. I kept telling people during that time that, there's this thing that we were taught since we were almost a week old, a month old. You will see the way we hold the baby and wash their hands. And we go back to the lower primary. We are taught when to wash hands. We go to the upper primary. We are taught to wash hands. Okay? And now we are graduates. We are still being taught to wash hands. What does that tell you? It's about personal responsibility. People kept challenging us, especially as who are in the medical field. Whenever you'd go anywhere and people know who you are, they will ask you, Daktari, are you sure? Can you explain to us? People even would go to the internet, do a lot of research and come and challenge us. This thing is, but I think when we talk especially with infectious disease, we try to focus more on something we call health promotion and prevention, which deals a lot with advocacy. And I think that's where not just our country or Nairobi, generally the way we do things in Africa, if I would say, we tend more to use threats. We don't take time to explain to people. If I tell you to stand 1 meter away, why? You see, that bit doesn't come out properly. One morning, everybody is told, if you do not have a certificate, you cannot enter a restaurant. Why? We need to tell the people the reason. Explain further. Why is it important to wear a mask? But you see, our narrative was, from tomorrow, everybody, mask. No, and that's the bit now I'm talking about some of the gaps that we realized was in advocacy. We were not telling people, so what does it mean when we say you cannot meet in a barrio? We have to limit. I think that's the missing. It's not that people are very difficult. It's just that in most cases, you'll come to my hospital or wherever, I'll tell you, turn around, pull down your pants. I'm not even telling you what I'm doing. So what will you feel? You will do it, but I think that is the bit that made people a bit resist the government policies that were in that place. It didn't come out clearly. Why are we doing ABCD? We were just telling people, do ABCD. And then, of course, even the people who are saying those things to be done are themselves not practicing it. So why would you expect me to believe you? You're telling me to do ABCD, and then the next thing I'm hearing, you are the person doing the contrary. Yeah. Okay. And then, of course, there's the other bit that was not taken also into consideration. These things come at a cost, which you are not prepared for. Number one, you are out of job. You are locked in your house. And then you are being told, you need a sanitizer, you need a mask, you need what. So, we also needed to have looked at the availability of this thing. I remember there are times a mask would cost 100 to 200 Kenya shillings. And they weren't enough. So you had to call and look, and where can I get one? So those are some of the factors that I think made the people a bit hesitant to, taking up the government directives. Okay, there is one that, because now, like I mentioned earlier, I was in charge of isolation and quarantine. And this involved both locals as well as international travelers, and even people who found themselves sick and within their household or at their workplace. And remember at the very beginning, it was mandatory. It was not optional. If you had contact with a positive COVID patient, you had to take a sample, which was not optional. If the sample turned positive, if the test came out positive, you had to undergo mandatory isolation. If the test came out negative, you had to undergo mandatory quarantine. Okay? And what I learned, or rather what I experienced, that was the most difficult time. And that's why it gave us, as a country, a very hard time. Because then in that case, even if I came into contact with a positive COVID patient, I would not self-report, which is what would be expected in a okay. It is expected that if I was with Dr. Matu and I knew I'm positive, I'm supposed to disclose to him and tell him, look, my brother, I have tested positive for COVID. But you see now, because of the way things were, mandatory at your own costs, you have to pay, it made people, shy off. Let's take an example of HIV today. If you get exposed to HIV, you quickly run to the nearest health facility and self-report and say, oh yes, I think I slept with somebody and I'm not sure of their status. Would you please, would want to take some tests and also some preventive measures? Yeah. You see, it's self. It's not coerced. And that makes it easy in controlling HIV. Because if you feel you're at risk, you opt for the tests you actually present yourself. We don't even come looking for you. But in this case, the story was different. My question is, how involved was the community, the people we are protecting, when you're making decisions? Do we sit in offices like this one, make decisions for people in Kawangware? Why don't we bring the people in Kawangware, we sit together, we agree this is how we are going to do? Then that way it becomes palatable and more acceptable. Remember, in the society we have gatekeepers, the church leaders, community elders, the mosque, the imams at the mosque. We need, in the event of another disaster, we need to involve the people who we are trying to protect. Let them give us their views, because this is a country which has very diverse cultural systems. You go to Isili today, or for 1 week, and then you go to Kawangware. Those are two different countries within a radius of 40 kilometers or less, with very different practices, very different way of doing things. So if for example you're targeting the people in Isili or Kamkunji, the way you package is different from the way you'll package for the people in Kibra or for the people in Karen. But you need to involve those people. One thing I learned during the pandemic, and it's always been said, everybody wants to go to heaven, but nobody wants. During the pandemic is when I realized there is no rich and poor. We are all fighting a common enemy. It didn't matter how much money you had, because even those who had loads and loads of money, even head of states, we lost them to COVID, with all the government resources and all their wealth and everything. So for me, the question would be, how involved is the community in decision making? Is for people to remember that the responsibility starts with yourself before going to others. So the responsibility starts. If I don't protect myself, I'm not protecting my family, and I'm not protecting my colleagues. I'm not protecting my friends. So it has to start with self-care.
Thank you very much. My name is Roslyn Ukabana. I work with Nairobi County Health Government. I head the Gender-Based Violence Unit, and also I am the Chief Medical Social Work.
What I do here is ensure coordination of psychosocial and GBV services within Nairobi County, and also provide support to the medical social workers within our health facility. Given the two roles, I am mandated to ensure that we provide prevention mechanisms, support systems, collaborative systems within other non-state and state actors to ensure that we reduce cases of sexual and gender-based violence within Nairobi County. My unit has been there way back now. It's almost 10 years when it was formed. And during COVID, we really had to undergo a lot of challenges because it meant working from home. And provision of psychosocial support for any person who is undergoing matters that are associated with mental is very challenging, in that sometimes it's important to have a face-to-face direct communication for you to be able to get exactly what this client is going through. So for us, when COVID came in, we had a lot of clients who needed to talk to us. But remember, for us, we were working from home. And it was not easy for the vulnerable members of the society, more so coming from the slum areas, to be able to even call me and tell me these are the challenges they are having, considering that they were also suffering on issues of not even being able to have a meal because of the time of the curfews that we had. And so matters mental health, matters gender-based violence were not considered. So we have been there and we have provided that support. And yes, we can. We did a lot of collaboration with those who are on the ground. When Corona came, we found the issue of curfews actually escalated the problem. And there are some spaces we never thought were safe until COVID came. And these spaces are places like schools, places like people even going to work. And that is when we noticed that when you're at home, a house can be very crowded. And when it's crowded, there are a lot of issues that will go on that will lead to a lot of quarrels, and later on it leading to what we can call something like intimate partner violence. Our girls were not spared because we had a high increase. During that time, the 2018-2019, we were by then only having about cases around 2,000 coming to our health facilities. But we noted after COVID, when we were doing our data, that we did have high number of cases. But remember, even coming to our health facility itself was already a stigma, because someone would be associated, you're going to the hospital because you have COVID. So the numbers that were coming to our hospital were limited, but the cases that we were receiving by phone from the community on issues of gender-based violence were very high. The highest number of cases that we got at that time had to do with incest. Fathers and their daughters, brothers and their sisters, and then of course the in-house parties that we all had that were going on during this little time that the adolescents, especially I'm talking about the adolescent because that was the biggest challenge that we had. So those are some of the cases that we had to walk through. And now one other thing that became a big challenge is the provision of medication. How are they going to get their medication? And how are they going to be even, you get a case, how do you report it to the police? Everybody is scared of going out. And that's how we were able to come up with a small structure together with partners and do what we were looking at, prepositioning of medications, prepositioning of safe facilities where these clients can go to, and also ensuring that they are provided with the minimum package of care despite not having our facilities. In Nairobi County, we actually were decided that we are going to use some of our health facilities as part and parcel of our safe spaces. And a facility like Mama Lucy Kibaki, where we have what we call Tumaini clinics. If you look at our directory for Nairobi City County, or you Google in our website, we have what we call Tumaini clinics. Why do we call them that? We call them Tumaini clinics because of restoring dignity to survivors of sexual violence. By that time, we had only about 6. That was Mama Lucy, Mukuru Health Center, Kasarani, Dandora, Mbagathi Hospital, although Mbagathi was not working at its full optimal. And then we also had private facilities that we also looked in, and that was Mater Hospital, where we had an agreement with them and agreed that in case they have any cases of sexual and gender-based violence, they will be able to provide services without payment. And we also worked with Coptic on the same. So we looked in, and because Nairobi Women's is known for providing services to survivors of sexual violence, it was easy sometimes for them to go there. And at the same time, we worked with organizations that partnered with us, and that is like MSF. With MSF, we agreed to have on standby ambulances as site facilities in the ground, more so in places where we had very high numbers of COVID. We were able to place ambulances within their places and ensure that the ambulances were stored with medication, and we were able now to work on shifts. As even healthcare workers, I get a clinical officer, a social worker, or a nurse, and a counselor to be able to provide these services. If the survivor is not able, we were also making trips to the home. But the problem again we encountered when we were doing this is we remember there was the siren. When anybody hears a siren coming or an ambulance being seen outside anybody's gate, it was immediately known that this is a COVID case. So that meant again that house needed underwent a lot of stigma and discrimination. So we had double work of trying to convince the community around it that these are other issues. And then also even taking the perpetrators to go to police was also a challenge because the police also were not ready. And COVID came in with, all of us had our own myths and misconceptions on how it spread, on how it is to be taken care, it's taken care of in terms of medication, or how are you getting infected? So anytime where you saw someone and our ambulance was seen or our partner ambulance was seen, those were some of the challenges that we underwent. And formation of community structures helped us a lot in that the use of toll-free lines was one of the guiding factors that helped us. And also just to ensure that the cases that were very, very bad, we actually agreed with our facilities that we would actually allow them to stay in hospital to reduce visitors so that even when they're at home and they're on medication, someone can be able to track them well. So those are some of the issues that we were able to work with. In the GBV programming, I have had to be able to come up with structures within the community. I have what you call GBV defendants. Some of them are women who have also undergone violations in one way or another. So we have formed what we call community technical working groups within the various sub-counties within Nairobi County. And then I have the social justice system. The social justice system encompasses teams of paralegals that we have been able to take them through for them to be able to be guided on how to track sexual and gender-based violence cases, to ensure that they link them up with the police, pick up the cases and ensure that the cases go up to prosecution level. And other than that, the paralegals are guided also that they can be able to ensure that when the cases are in court, they're able to remind the survivors when to go to court. And then some of the social justice systems have been supported, whereby they're also giving transport to the survivors to go and collect, for them to be transported to go for cases when their hearings are coming over. Other than that, we also have male engagement, groups of men that we also worked with to be able to support us in this framework, so that most of the time men are seen as perpetrators. But we were looking at a situation where we're looking at men as protectors and not as perpetrators, so that they can, their role majorly was to ensure that they are able to pick up some of these cases and be able to talk also to the men to ensure that we reduce the number of cases that we were having. And also just look at what are these societal things that are causing men to go over and beyond what should be as a man, where you're a father and you're looking at your daughter as your wife. And how do you be able to support your family so that the issues of intimate partner violence don't even come in, considering that we are all in one house for so long. So that was also a very big challenge for us. And then other than also having male engagement, we had what we came up with as survivors of sexual violence. We call it Survivors Network. So the Survivors Network acts as a peer. So they were also able to support us in following up cases of survivors of who have undergone sexual violence or gender-based violence, and work with them as peers in the situation where we were not getting immediately counselors or psychologists to be able to walk them through as a peer-to-peer. So those are some of the structures that we have in. And other than that, we also used our safe houses. But the safe houses that we have in Nairobi by then were not manned by the county government. We do not have our shelter of our own. But now within the last 1 year and a half, we've been able to come up with one. So the shelters that we had, through the National Gender and Sector Working Group, we were able to support these shelters by giving them a fund, and for us looking at survivors and supporting them with food baskets weekly and providing them with a stipend of 6,000 shillings to be able to take care of themselves and also themselves as supporters of, the survivors of sexual violence, and also to look after their family members. Because sometimes you'll find some of the caregivers who are undergoing violations are also mothers, and they're also daughters, and they are people who by then didn't have any work. So those are the systems and structures that we had in place. We actually gave them 6,000 per week for 6 months. Yeah, supported through Oxfam, CRU, and Wango Kanja Foundation. And what we did, we asked, I'd forgotten to say, we also have, like now that I head the SGBV unit at the county level, I have a structure of SGBV focal persons within the sub-counties who now are able to cascade these services within, collaborating and coordinating these services at the county level. So we asked them, they're the ones who knew the survivors who had come to our facilities, and they were able to recruit them for us. And we were able to actually vet them, because one of the things was you had to have undergone sexual violations. You had to undergone at least one form or the other of gender-based violence. And talking about gender-based violence, we're only not talking about sexual. We're talking about physical. We're talking about emotional. We're talking about economic. We are also talking about, in quotes, I don't like using that word, what we are calling child marriages, because child and marriage should never be in one WhatsApp group. There's no way a child should ever be in a marriage. So, but then we had those cases. And these were some of the cases that after that, we found out that we had very many cases of adolescent pregnancies. And again, because ARVs were being given after 3 months, our infection rate for HIV also just went up in that manner. So we had quite a number of adolescent girls who got pregnant. For the girls, it was even worse. When you look at a place like Kibra or one of our slum areas, whereby you have to use public toilets. These public toilets are paid for. When the children go to school, the parents don't have a budget for the toilets. But now when children were at home, it meant that parents had to pay even for use of the toilets within our slum areas. So that added another burden. So for our young girls, getting just 10 bob or 20 shillings to go to the toilet, and you get a boda rider who's ready to give you 50 shillings for all your people for a 1 minute stand of sex. That is how many of our young girls got now involved in getting that, because of the use of toilet and bathrooms. And then the same also goes for the issue of sanitary pads. And one of the things that some of our partners came up with was also provision of sanitary pads. But again, it meant that most of the people who were requesting if we could, most partners had not budgeted for dignity kits. And we noted that even as we were giving them, you take to a family a dignity kit that contains toilet soap, tissue, it contains a bar of, a toothbrush, a toothpaste, and it contains also maybe an underwear for a girl and boy, and Vaseline. Now the parents were finding it better. Now you take them a dignity kit, they sell the contents and now remain with the sanitary pads for the girls. So that again brought in for us to the community, and we found that they found a better use of more than we thought was needed at that particular time. So those are some of the structures we had in place. And also we had reporting mechanisms. The community is able to report to the sub-county GBV focal persons of a case that has happened and maybe has not accessed the hospital. And then for us, then we are able to send an ambulance to go and pick the survivor. But remember, sending an ambulance is stigmatizing the community because to them already owed him to a COVID. So we had again to find a better way. How do we do it? So we worked again with the community. Now we are calling them community health promoters. By then they were the CHVs. We call a CHV who has undergone training, send them to that specific, give them the contacts, they go to the house, tell them to walk to a certain distance, and then we will be able to collect the survivor from there. What was the risk there? The risk was loss of evidence that was to be collected, evidential material that would be collected to ascertain a case. So that proved again a challenge for us. I remember one time I personally had to move from where I stay and tell a caregiver, bring that survivor to the facility where I was. And by then I told them, well, let's meet at Umoja Health Center. But when the child was being brought to us, we noticed the fact that they walked for some place to where we had lost a few evidential material that would have sustained for us to keep up that case as it goes to court. So those are some of the challenges that we underwent. And even you remember that time the cases were not going, courts were not sitting. So we had a backlog of quite a number of cases that we had to deal with. And despite the high number of cases that we had, if I remember very well, I only had about 18 cases that went to court. And out of the 18 cases, only 2 were able to go up to the end of the prosecution level, where were able to sustain a conviction. Initially, if I look at it also, we also had to blame us as the healthcare providers because maybe our documentation was also not good. Collection of evidential material, survivors and caregivers not wanting to come to go to court because maybe they know the perpetrators, so their lives are also at risk. The attitude of our police service then was also not, I don't blame them because COVID was very new to everybody. So everybody was looking at how best to prevent themselves. So they will tell you, kama ni kitu kama rape, hiyo ni kitu mtaenda msikizane nyumbani. Ni nani ni baba? Nawe mama, sasa ukikataa, sicha pesa yako ya nyumba itaisha. Endeni msikizane. So they would send away. So the police officers now became the judges, the jurors of what the cases had been done. And that really messed us up in one way or another. I think having been in the GBV world for more than 13 years, there's been a change in the police force. They are more positive. Their attitude has changed. They understand. And I think the fact that cases of GBV are not only focused to one gender, that they also have their own who had undergone, the attitude might not be 100%. But for me, having worked in this sector and the collaboration and the work that we do together, there's been a very big change within the police force. And other than that, the National Gender and Sector Working Group, they are part and parcel of that group. And we have cascaded it, like I had said earlier, up to the sub-county level, where they also sit in those committees. So we allow them to come and we allow the teams to come and bring in their complaints when a case has not been handled well. They also come in and then also working with the girls, the chiefs. In fact, sometimes I feel even the chiefs do us more injustice than even the police, because the chief is the first person where a survivor of GBV will go to. And the chief knows everyone.
Yes.
So the chief will be like, Madam, kama mzee alikuja amechelewa na akakupiga tu kakofi kadogo ndio inafanya unapiga kelele. Hiyo ni kitu tunaweza saidiana. Wacha tutaita mzee, and they send you back home. So those were some of the challenges that we underwent. Yes. But in some households you will find, because society and the patriarchal norms are very clear, that a man is a man should do this, a man should not do that. So, and then women tend to again hold back. But with the empowerment that we have received and the support from state and non-state actors on supporting the empowerment of the girl child has brought in a difference. And yes, we will complain and say it has also made the boy child now be a victim of circumstances. But my take is, when women are empowering the girls, where are our men to empower the men, to empower our boys? Because even the information that we are giving to our boys as empowerment is coming from us women. The men have very little time for the boy child. So if our men also took it up, and that's why I always fight and say, if we do not have a leadership that recognizes that GBV is a two-way, there's a boy and there's a girl. For us to make it work, let us empower the boy, empower the girl. Let the boy know why it's wrong to beat a woman. Let the girl know, I do not need to talk in a high-pitched voice for this man to be able to listen to me. We need to complement each other. And I congratulate the government, because one of the thematic areas that we were missing out in all the thematic areas of gender was the issue on male engagement. And our government currently, the other day with the Mheshimiwa Jumwa, we launched the 5th thematic area, of where now we have male inclusion and male participation and male engagement in matters gender. We look at that gender lens in an open manner, whereby we know men have their roles, but at what level do we then complement each other to ensure that we reduce the patriarchy that has been ongoing, and not because we want it, it's because that is the way we found our society. But we have the time to change it, and we have the time to make it better by ensuring that the boy and the child and the girl, all of them are at, they might not be at par, but they have equity in the level that the boys were. COVID taught us lessons. COVID taught us that in everything we do, we should always have a plan B. COVID taught us that there are spaces that we have assumed into our heads, but actually are safe spaces for our children and ourselves. COVID taught us that a hospital building alone is not enough, that it needs qualified staffs, it needs proper drugs, timely drugs, people who are aware, people who are ready to provide emergency services at any given time. COVID taught us that HR is very important in a health facility. COVID taught us that the community needs to work together to ensure that as a community we can be able to fight a pandemic that comes in the way that COVID came in. Remember the issue of masking. Not all of us were in a position to purchase masks. But then it showed us that we can be able, with a small working together, we can be able to support that other community. My take is, let us always be prepared for any eventuality that comes. The community should have its own mechanisms to sustain itself. We saw that we relied so much on partners, and there's something that is called sustainability, that we must work as a country and as a county. A partner can come in, yes, but we must have a sustainability plan always. Thank you.